Yep.
So today is the 12th of December. The World Health Organization and the UN have many days that they commemorate. So today we are commemorating the Universal Health Coverage Day. And in this slide, we thought within the Pan-African Health System and the Health Research Foundation represented by Prof. Sylvester Ndeso Atanga to have our own discussion on our thoughts and share our thoughts on what we think about the universal health coverage and how we think we can come up with practicable methods to make this dream come true, because the agenda of the Universal Health Coverage 2030 is to make healthcare service accessible to everybody. But already we are 10 years up to that task. Are we sure we are going to make it? Are we sure even the minimum healthcare access or healthcare service is going to be accessible and affordable to all those, even those in the hinterlands? Are we remembering the missing communities that are not even being able to access normal transport infrastructure? And what modalities can we use to be able to make this universal health coverage dream come true? And in that light, we are going to have our keynote speaker is going to be Professor Sylvester Ndeso. But before then, we will have a brief introduction of the Pan-African Health System for Cameroon from Mr. Ayi, and also a short presentation from Mr. Keltis Menimbo-Ategang to talk on health financing, healthcare financing, and to present to us his paper that he was recently published. So I'll welcome you all, and we scheduled this meeting so that it should not take too much time, but it is being recorded and we are going to be able to upload and have more further deliberations on our thoughts and how we think the impact of the universal health coverage can look like. So welcome, Prof.
Thank you.
Mr. Ayi, are you ready for your short presentation before we move to Prof. Mr. Ayi, you are the host of this. Mr. Ayi, you are still muted.
Oh, I've not lost him.
Can I? Okay.
Go ahead, sir.
Okay. Thank you, Doctor. Thank you, Prof. And thank you all the participants of this occasion of the Universal Health Coverage Day. I just wish to make a short presentation of Pan-African Health System Network in Cameroon. In fact, the person started introducing Cameroon by April, May 2021 by the founder and CEO, Dr. Bernard Taylor. So I was maybe privileged to be nominated as the coordinator for the country. Humbly accepted the position. Now, globally, PASSN is a German-based NGO, not-for-profit organization, whose aim is to optimize public health delivery through the advancement of digital health by promoting collaboration between the health communities and the digital or technological world in order to make research, teaching, promotion, and to adopt the best practices in the delivery of digital medicine. So that is globally the aims of PASSN. And then this PASSN has several divisions. And the divisions include biosecurity, digital health, we have clinical research, health promotion, especially now as the promotion campaign concerning the pandemic. PASSN is involved, has written several letters, are involved in that campaign for vaccination, prevention of diseases, awareness, and so on. There's also the branch on global health, which we're looking at financing and data sharing. Then we have equity, trying to make sure that health reaches everyone, irrespective of gender, age, and race, and especially to target the underprivileged or those who are in the rural areas who do not actually have access to public health. That is one of the key areas that person will be trying to see that health can reach everyone. We also have areas like I've talked about biosecurity. We talk about health services, which will include webinars, symposiums, and consulting. Then within the person as an organization, there's the in-house organization, which is the Community Digital Health Hub, which is a model, I can say, flagship organization, which person wants to use to actually concretize this vision of bringing digital healthcare to everyone. So it will be like a Community Digital Health Hub is like that hub that would be the experimentation, research, and try to implement this vision of person. And person is also working with several partners in collaboration with several partners like the mental health system in Bamenda, the rural doctors in Roya, Digital Message Society, and recently we entered into a very sound memorandum of understanding with the St. Monica University and Health Research Foundation in Boya under the aegis of the most able Professor Sylvester Atanga Ndeso, who is also the keynote speaker in this conference today. And within that understanding, the Digital Health Hub will actually be hosted by St. Monica University under its Health Foundation. And that's where the stories will begin to see how this dream of a digital health can actually be implemented. There will be research, there will be online trainings, and to make sure that the vision of a digital health will be concretized on the ground to suit the purposes of the local communities. It means to bring that technology down to earth to suit the local communities in Cameroon and around. Person is also working with other foreign bodies like Stop Harassment and Online Abuse of Women, SHOA in Gambia. Unfortunately, due to maybe the climate in Gambia now, due to the presidential election, we have not been able to have Madam Annette to participate, but I think next time she will be with us. And then these are actually the organs. Now in Cameroon, having made this presentation, I wish to, the platform, we form a platform here, the Person Cameroon WhatsApp chat. Now we have about 40 participants on the chat. But what is the main problem here is that people don't want to, many people don't want to join organizations or this platform that they think that when they say we need to work, we need to research, we need to crack heads. Many people want to join something which is already made. But I am happy that in this platform, the hopes are high because we are getting through to innovate, to create, and to bring solutions. And I think those who will be able to join the vision of Dr. Atega in bringing this platform to base on research, I think at the end they will not have to regret, because when we invent and bring innovations, we have this out like person that look at it as a global organization, which is as a portal for us to be able to prove that we can deliver goods, that we can invent things, and then we're able to have access through the credibility of person in order to access the necessary finances and technical support that we need in order to bring this thing to happen. And we have as a duty within our own country, Cameroon, to bring these activities, this vision, this vision of person down to earth. I say it must be born fruit on the ground to suit Cameroon and our local communities. And I'm so thankful humbly for the privilege have given to me, and I call on the collaboration of all of us to make sure that we don't look at what we have to gain now, but we look at what we have to do in order to gain confidence of the global partners who are ready to sponsor, ready to work hand in hand with those who want to provide something for the communities. Once we have achieved our aims, I believe people were looking for us to work with us. We will not be looking for people. So I don't have much to say. Maybe on through the meeting, I may have other things to say. I might have omitted some things, but I have a doctor is there, Mr. Curtis normally is there. Maybe they can chip in other things to maybe fill in what I might have forgotten saying about Person. Person is taking off in Cameroon, probably by 2022 coming. We will have an office is ready, is getting ready. Other logistics are getting ready. As I mentioned, the community digital health hub will be taking form here in Boya in the partnership with Monica and the Health Research Foundation. So I think that the Happy New Year to Person Cameroon is that things are moving from theory to practice, from vision to implementation. And I'm grateful and happy to be part of this. I wish to Dr. Thank her so much for that initiative. And we look forward to seeing the best being done. Dr.
Sure. Thank you, Mr. Ayim. Thank you. So I will just leave this question session maybe later. When at the end people have questions, they can get to you. So we leave enough time for our able prof to for his keynote. But so Mr. Curtis, I hope you're going to also maintain the time frame and to take over your presentation on health financing in Africa, especially for the case of Cameroon, because finance is one of the main pillars of universal health coverage. Yeah. Do you need to share your screen, Mr. Curtis?
No, I don't think so.
Okay.
Okay. That's my greet to all. On the occasion of the celebration of the Universal Health Coverage Day, I wish to make a presentation on the research work which was made published December 4th, 2021 on the Auditum publishing site as an international journal of the epidemiology and public health research. This research work was entitled Financing in Health Care in Africa, the Case of Cameroon, written by Curtis Manimbo-Atega, of Ndeso Sylvester Hatanga, of Genkafak N, Fabella Gottman, Ndem Ayin, Nwakongo Glory, Okochukwu, and Dr. Bernadette Atega Awankem. Came from the following occupational fields: Pan-African Health System Network based in Nussloch, Germany, Faculty of Health Sciences, University of Boya, Cameroon, St. Monica's University Institute, Boya, Cameroon, Healthy Environments and International Development, Nigeria, Nnamdi Azikiwe University, Akwa, Nigeria, respectively. The introduction part of this research work looks at the study area Cameroon, its population, income, and the situation of the medical infrastructure, hence its level of preparedness when it comes to facing complex health situations like the corona crisis in which we find ourselves and other tropical diseases. Then we looked at the structure of the health system in Cameroon, which was at 3 levels, hence permitting us to come across the various actors responsible for providing healthcare facilities in Cameroon, amongst which were mission hospitals, NGOs, and other bodies responsible. To begin, as you all know, medical expenditure in most African countries is financed by individuals, mostly through various means and mostly through out-of-pocket expenditures, which is mostly done through their own little savings and other financial sources. Financing for this healthcare expenditure is usually not easy, especially in Cameroon, where the per capita income is very low when looking at the population. To this effect, knowing how the population manages to survive in situations like this was of great importance. So to have a better understanding of this, the government expenditure of health in Cameroon was compared with that of other African countries like Gabon, which showed that Cameroon still spends less than 5% of its gross domestic product on health, which is considered as being low when looking at the standards of the World Health Organization. Looking at the world at large today, we see that the health system in most developed countries is facing enormous challenges following the outbreak of the COVID-19 virus. Before its official declaration as a global pandemic by the World Health Organization on March 12, 2020, Cameroon had its own first case on the 6th of March. On the 6th of March 2020, reasons why this research work included the impact of the COVID-19 on Cameroon and how its government is surviving amidst this pandemic and other present crises. All in all, this research didn't only end at identifying difficulties in the health sector, but also went as far as to make some proposals or recommendations regarding health financing issue in sub-Saharan Africa, which could help in combating some of these health problems. At the end of the day, we hope that this research work will go a long way towards educating the health sector in Cameroon, Africa, and the world at large. Thank you so much for your attention. For the presentation, I have been Curtis Manimbu Atega, a student volunteer researcher at the Pan-African Health System Network.
So thank you, Mr. Curtis. I hope as we are going to, after Prof's keynote, all of us are going to join in reflecting and being finance being a key part. I would also like us to bank our questions. Please take note of the questions, and then we are going to go into a general discussion. So now, let me turn to Prof Sylvester Tanga. Prof is going to present our keynote for today, and Prof is the Dean of the St. Monica Institute of Health and Human Sciences, and also
Human Services.
And Human Services, sorry, thanks for the correction. And also the founder and chair of the Health Research Foundation Cameroon. He is also part of many think tanks that have been working towards ensuring that we have quality research and thinking of and health system thinking towards the health service access across Africa. Without much ado, I'll hand over the day to Prof to give us his presentation on his concept of the universal health coverage and what homework he's going to give for all of us by the end of today. Over to you, Prof.
Thank you very much, Dr. Bernadette, Curtis, Mr. Ian. Is that all we have? I thought there would be more people because of very novel ideas that I think we can share.
We have Mr. Glory Waka here, who was also the co-author. That's why I said we are recording the meeting so we can be able to share it, disseminate it later on. Thanks, Prof.
Beautiful. Thank you all for joining. And today is Universal Health Coverage Day, and it is being celebrated all over the world in the Africa region of WHO, the Mediterranean region, the Pan-American Organization region, the European region, all the regions of the World Health Organization are commemorating this day today. Now, universal health coverage is not new. the concept is not actually new. It can be traced back to 1978 at the Alma Ata meeting in Russia, where primary healthcare was born. If you remember at that time, after the end of that particular meeting, the world decided that they will aim for health for all by the year 2000. If you can remember that very, very well. Okay, fine. So you see, universal health coverage, health for all by the year 2000. Universal health coverage also means health for all. That's what it means. So it's really the same philosophy that the world had been struggling with since 1978. So you can imagine. Unfortunately, disparities in health continue. But before I get into the real meat of my work, my talk this afternoon, which I'm going to see how far the world has come by these two very famous positions in 1978, again in the year 2000, which that goal was not met. Then another 15 years was added, as you can remember very well, the Millennium Development Goals, which again was not quite achieved. And then now we have the Sustainable Development Goals. Health for all continues to figure in these agendas. So the Agenda 2030 has universal health coverage as one of its principal targets to meet. But what is universal health coverage? I think we need to get a better understanding of that before we proceed. Universal health coverage basically means that health for all, okay, that all people have access to health services they need, when and where they need them, without financial hardship. That's what it means. That people are able to get the health services they need, wherever they need these services, without any financial hardship. It includes a full range of essential health services, okay, as you can imagine, from health promotion to health prevention, treatment, rehabilitation, and palliative care. That's what it involves. Currently, at least half of the world population do not receive the services, the health services they need. About 100 million people have been pushed into extreme poverty, believe it or not, because of their out-of-pocket expenditure on healthcare. Okay, this has to change. That is what the world body is thinking. You can't have poor people spending money for care which they don't have. It just renders them extremely poor. So to make health for all a reality, we need individuals and communities who have access to high quality health services so that they can take care of their own health, okay, and the health of their families. We also need skilled health workers providing quality care. We need people who are people-centered oriented. We need these are the type of individuals we're looking for. And we need policymakers that are committed to investing for universal health coverage. That's what we need. Without this, it becomes very, very difficult to accomplish this very, very essential goal that the world has set for itself. So universal health coverage should therefore be based on strong people-centered primary health care. Should be centered on that. So good health systems are rooted in communities that they serve. And I think that's what we're trying to do at Triumphs. They focus not only on preventing and treating diseases and illnesses, but also on helping to improve well-being and the quality of life. So this is what, an overview, that's basically what we mean when we're talking about universal health coverage. Okay, so and I've given you some statistics. I can add more. Over 930 million people in this world, and I think that's being even is very conservative, spend 10% of their their household budget on healthcare. Okay, so universal health coverage means a fairer type of system, healthier people in a healthy world. So that's what we mean by that. So now the question is, are we going to achieve this very, very lofty goal of health for all again by 2030 and the 2050 agenda? What is it that we are going to do differently that we have not done before? I think the answers are there. We need people-centered actors who are people-centered. Okay, I think we've said that before. And if we don't have those type of people, again, we'll just still have slogans. Governments need to be able to be ready to spend their quota that was prescribed by WHO years ago, close to 15% and over of their health, of their GDP on healthcare. They need to do that. Until they do that, this is not going to happen. It's going to be almost impossible. You can do all the talking we like, and then nothing will happen. We also have to start thinking seriously about even starting health insurance programs nationally for all citizens in the countries wherever they find themselves. This has to be well planned. Health insurance is not a new idea. It exists in the world. Some countries have demonstrated that it can work. If you look at a country like UK with the National Health Service, that's a typical example. If you look at the German system where you work with their health services that are provided almost free through their own socialized type of system there, you realize that those countries are making headway, and it is working. It is working. If you look at a country like Ghana, which is now has about another 15 years experience in venturing into this, you realize that it is working. They started it and they made it compulsory. Households, no matter how much you earn, you pay a modest amount and you get access to health services. It works. It's a political will, and organize, just like you're doing a campaign, a political campaign, you can take that too as a good campaign and you get people enrolled in that system. It's compulsory. Some of these things, you don't need to give people any leeway. You give them freedom, they don't do it. Okay. In Cameroon, we have not attempted it, but we're seeing some vestiges of it that it can work. We have the Catholics. They put up the BIFA program, which is a health financing system, which pays 75% of your healthcare bills, and then you pay only 15%. You can enroll your entire household family. This has been going on for about almost 24 years now. So it was introduced by the Catholic health system, and others are buying it. The government attempted a mutual benefit type of system too, but you know how government things are. Nobody knows to what extent it went to, but they almost died a natural death. You hardly hear about it. But the BIFA, you're still hearing about it, because again, the church, they tend to be very active and tend to be very serious in things that they do. So that one is working and helping some families to take care of their health bills. The private sector in Cameroon, of course, if you work for companies, because health is one of them. So they do have partnerships with insurance corporations where some deductible that the employers pay, and it's cut directly from the payroll, and of course, so they're able to take care of the health of their employees. So that is basically what happens in Cameroon. South Africa is also very far advanced as far as getting some insurance for its people is concerned. Nigeria, a very big country, again, you have pockets of experiences, again, with companies, the private sectors and all that, but not government action per se. In the United States, you have it's a typical capitalist system, and it's very, very different from the rest of Europe. Europe does have health insurance to protect the health of its people, and it benefits even those that are not quite rich. America is different. America allows the private sector to do it, and the government only comes in to take care of the old and the disadvantaged populations under their Medicare and their Medicaid system. Okay, Australia has also mimicked that type of system, and Canada also is taking some part of that type of system. Okay, Brazil is dealing with health insurance the way we know it, but national health insurance, again, by getting people to contribute, and it's cut directly from the source, from tax revenues and all that, and then with government subsidies and all that. So in general, countries are making headways, but there still remains a fundamental problem as far as developing countries and resource-poor countries are concerned. They are not making it. They are not making it, and they may still be condemned to paying from their pockets if something is not done. The only attempt, of course, is that is a little bit rewarding is the primary healthcare system, which was introduced, like I said, in 1978 by Alma Ata. It has gone through a lot of reforms, a lot of remodeling, and the height of it came in 1988 when user charges were introduced. User charges were introduced as a way of helping an institution raise some revenue, and that revenue could be used to ply back into the system to provide the health services. So the population contributes, they participate in that type of a system by paying some modest token for consultations. Like, for example, I give you a good example. Consultations, general consultations can be like, say, 500 francs. Obstetrics can be like, say, 1,900. Laboratory, but another 1,000 francs, and so on and so forth. So this money that is paid in is then used to supply those, to buy back those perishables that we use in the hospital all the time, from cleansing solutions to bandages to forceps and all whatnot. Those things that will perish in a short space of time. It cannot be used for any heavy type of equipment. That is again left to the government. So that system has generally ensured only one good thing: access to medications. That is what that system has actually ensured. Access to medications, access to treatment is what most of those health centers in countries that are practicing that system of primary healthcare through user fees is what that has achieved. So before, you could go to a health center, they will give you a prescription. You look around, there will be no pharmacy even in that village to buy the medication. So that is a non-issue now. You can now go to a health center, you are diagnosed and treated on the spot because there is a pharmacy right there in the hospital and has all these essential medicines which have been which is being run by this user fee system. So they also encourage them to keep most of the proceeds to make sure that the hospital keeps functioning and all. And that's where maybe some hope may lie for people who are not that rich, that they can have access to essential medicines. Now, the question is whether that also provides quality care. That is still debatable. But what I can only say is that that type of system would take care of your common ailments, from your malaria, your typhoid, your dysentery, your shigellosis, all the hepatitis, and all those common local conditions that people suffer from, respiratory problems, pneumonia, colds, and all that type of stuff. That's what people may gain from. So I think that's what they will get. But again, it's also good because you can imagine that if that system was not put in place and it's not working, again, people will suffer. So one can comfortably say that at least they pay from their pocket, yes, but as far as primary healthcare is concerned, they will get the basic care that they need. On the other hand, if they need specialized care, unfortunately, without insurance, they have to pay from their pockets. And that is where the poverty comes in. We've seen it in many instances. Poor people end up in the hospital, appendectomies for 200,000, C-sections for 300,000-400,000 francs. Just imagine, so who can afford that? So people die, people develop complications, people have to go back in because again, when you don't have the money, apparently you also get quality care. As simple as that. So it's a problem if they have to seek specialized care. But if it's only primary health care, they're fine. But I think that seems to be the problem that we have in this system. So the key, of course, is to introduce some kind of insurance. That's what all this is heading to. This universal health coverage will not be achieved without some form of health insurance, organized by nations, by nationals, by governments, on the models that work. What models that work? I've given you examples. The National Health Services in Britain, the system in Germany that we have there, the system in France. And I don't know why we cannot take these systems. We can. You can, if of course, if we give it political will. So working through our legislators, they have to understand that health is a human right. Health is a human right. And based on that premise, people can then push their legislatures to ensure that people get accountable and get held accountable for if they're not providing these kind of services to their common to their citizens. It's important. It is their right and they need it. So, but if we only use these slogans and don't do anything, like you said in your opening remarks, we're already 6 years into this scheme from 2002. No, 10. I'm getting to 10. In 2025, will be 10 years already. So we're only left with 5 years. The question is, are we going to be able to achieve this universal health coverage? I doubt it. So what I think is that we need to then start working out schemes. Communities have to organize themselves through their governments to see exactly how they can organize some health insurance. Advantages abound from other countries that have this experience. So if we can imitate them, I think we'll be able to solve the problem in many countries. I don't know what many other developing countries are doing, but they will not be far from us. And the solution that I'm giving is going to be the same. It's going to be the same. They have to institute health insurance. You organize it. And it's not a question of cost. Cost not come in. Because we have seen that if you are to use finance as a serious deterrent to health, you'll be making a mistake. Because we have found out that people will spend because they value their lives. See, they really value their lives. People will spend when they are sure of quality, when they are sure that they're going to get well. People will spend. So that myth that finances, lack of money and other stuff will deter people from seeking quality care is a lie. Our studies have shown that people are willing and able to pay for quality health services. They will pay. It just depends on how you organize it, and they will pay for it. So this is what I'm bringing. And these studies, some of these studies that I'm quoting are studies that were carried out more than 15, 20 years ago, and it was found. We saw this. A clear example is that if you see where Reverend sisters are operating their small health centers in remote areas, people are paying for those services and getting their services. They're paying for them because they value the care, they trust them, they know that the care is good, and they pay. So to put that idea that they will not be able to pay is not true. Just organize them and tell them what their contribution is, what they ought to do, and then if you even make it compulsory with every household, they will not refuse as long as they see the benefits. When they start seeing that, hey, you can now actually go and have that surgery which you were paying 200,000 francs for, or perhaps you pay 25,000 francs for it. See, that is it. That is it. Then they will take it up. So I think there's a lot that has to be done in terms of health promotion. Teaching people about their attitude, their belief patterns, changing some of those belief patterns, cultural patterns that don't work, that are detrimental to health, encouraging those that promote health and all that, and showing them the advantages of doing the right thing. Teaching them the sense of prevention, preventing these common illnesses. You can't keep having episodes upon episodes of malaria every year. Eventually leads to complicated malaria that will cost you more than the 500 francs that you would have spent to treat your malaria if you were doing the right thing. Encouraging people to sleep under hospital mosquito insecticide treated bed nets and all that. These are things. Encouraging people to drink clean water, to have potable water. Encouraging people to through community participation to ensure that they can at least provide water for themselves rather than waiting for somebody. These are all secondary and very active determinants, social determinants of health that are very, very important. Encourage people to eat balanced diet and all that. Some countries have food like Cameroon, but the problem is whether this food is available to everybody. Some areas have, some areas don't have. There's some problem of distribution, which is also a problem. Issues of equity, making sure that we don't discriminate and that people have equal chances of getting the right care. I think if we do this, we will be on our way to achieving this famous universal health coverage that I'm talking about. Finally, I need to talk also about building capacity. I think we do have the manpower. We're training manpower. We're training a lot of manpower, especially with the general basic skills. We're doing that a lot. And unfortunately, they're not being absorbed. Yet, we complain that we don't have healthcare workers. We are training them. They're spending their monies. Both the public and the private sector are training all these healthcare workers. So I think that looking at the universal health coverage, they are there. You may only need to improve their skills vis-a-vis the clinical services that you want them to master to be able to provide better care. But they are there. You can also encourage specialization for those who need to be specialized. And I think a country like Cameroon is doing by far better in terms of health manpower, in terms of the training. If they don't get hired at home, they go out. Drain. The country loses. Another country hires them and they work. This is going to be very detrimental for universal health care coverage. They will keep training people and the people keep living. If our good, skilled workers keep living because we cannot absorb them and make them comfortable, it becomes a problem. So when we are doing universal health coverage, we'll be thinking about all these issues. How do you retain the manpower that you have, the health manpower that you have? How do you retain them? Good working conditions, attractive salaries, they will stay. They will stay. Equip the hospitals. Cameroon has a lot of infrastructure. It's there. The buildings are there, empty. You need to now equip them and put the right people there. With some refresher training and technical training, you can render most of these institutions tertiary care facilities. I see them looking for donors to come and build hospitals, to come and build a regional hospital, What's the use? You build one regional hospital and yet people will still have problem of access. Why not just strengthen the capacity, the quality of those that you have? Let me give a breakdown for you. Cameroon at the central level will have category A hospitals. At the regional hospitals, a lot of regional hospitals. All they need to do is to increase the quality of care in these areas, and I think people will do well. So I think without much to do, I think in terms of healthcare costs, which is also going to be a very, very strong factor in this universal health coverage, as like I said, governments have to increase their share of the required levies that were imposed on them on their GDPs in order to improve their healthcare. You can't be spending 3% or less of their budget in healthcare and they are talking about universal health coverage. It will not work. It will not work. You should spend at least 10%. At least. I mean, yes, you should. It's 15%. But if you spend less than 10%, you're not doing well. You're not doing well. So that has to happen. If that happens, then I think we should be able to move closer to achieving the 2030 agenda on universal health coverage. I think, let me see what I'm leaving, something else. Okay. Governance. Yes, the health governance, very, very important. Democratic governance is very, very important. Making sure you have stakeholders represented, making sure they take part, communities take part, even the policy agenda in putting together your policies, making sure key actors are there, making sure, in fact, and open it to be competitive, because it's very, very important, because there's no use for a few people called health experts to sit down and try to put policies together by themselves. They don't work. When you are building health policies by yourself, they will not work at the local level. When it comes to implementation, it will fail. So you need to have, you need to enlarge that, and so you make sure that there is equal representation as far as policy is concerned, so that the policy reflects the real needs of the real health needs of the people. So people have to determine and know what their health priorities are, and then work with you towards achieving those priorities. Not you coming to tell them what the priorities are. If you come from outside to dictate to people what their health priorities are, I'm sorry, you will not get any headway with them. Because when they now know what their priorities are and they're defining and telling you, they will take charge of it when it comes to implementation. If some funding is found to resolve those problems, they will be more responsible, more accountable, and they will even hold those who are skilled, like the providers, the clinical providers, they will hold them to task until they do exactly what the project or something said they should do. Without this participation, when you leave out people in their governance, in their governance systems of health, I'm sorry, it will not work. It will not work. So I think those were the most important things that I thought I would cover in this talk. So thank you very much.
Thank you, Prof. Thanks. You have really covered the key issues of health access and the universal health coverage, ranging from, on one side, the quality of services. And you made mention of the fact that finance is not the limiting factor because people are already paying out of their pocket. So what is necessary now is if the government or whoever is setting up a primary health center, when the quality is good, people are going to be willingly contribute, especially if the government should come up with an insurance scheme, and which is actually necessary. You also talk about the issue of workforce. In many countries, even here in Germany, people complain about the limitation here is workforce. Like you said, for example, in Cameroon, both the government and the private sector train people, but they are not being absorbed into the system. Now that brings, that opens to the question, how do we make the healthcare sector an economic sector that can actually self-employ people and give people the room to create jobs within their communities? And thirdly, also one of the key things is that aspect of governance. And if governance, by saying governance, if we should take back the communities and also involve the communities in decision making, it will also be easy to solve most of the problem along the chain of the universal health coverage. So now, Prof, from the perspective of Cameroon, we know many villages have their development organizations, and those development organizations had participated in had played a key role in bringing both clean water and education to the communities.
Correct.
From your point of view, how can we actively engage the community development organization to add the pillar of health into their segment, so that why the state fails, the local governance from the communities can actually also participate in setting up quality systems of health and also reducing the cost of each person in that community. So I'll just give up that one question, then I'll open the room for others to come in.
Definitely. The approach, of course, is to do what we call a community diagnosis. That's the first thing. The community diagnosis for health basically means that you go to the community, meet the key people that are in that community, what we call the key informants and the stakeholders in that community. The key informants will range from your retired teacher, retired nurse, retired bill, retired that, then the chief himself, his quarter heads and all that. Those are the people that make up that particular system. Then you hold town halls with them, hold meetings. The idea, you work with them. They will be the ones who identify their health needs for you, not even you.
Yes.
Yes, you work with them until you identify those needs. But before doing that, you yourself need, of course, to know the community. You must have studied the geography of the community, the history of that community, the population makeup of that community, their activities, their commercial activities, okay, their agricultural, their feeding system, their housing types, and all that type of stuff. You yourself would have done that first, as with your researchers. You would have had good knowledge for that community. Then you go in now and then meet them now, and you then, by doing that diagnosis, that first diagnosis, without involving them, you will even be seeing some of those things by yourself, because you would have now known by your inventory that, okay, this community only has about one hospital. It has a population of this. You know immediately that there are inequalities. You will know that immediately. So now, but when you now do this needs assessment with them and identifying the health needs, then you prioritize them. Once you prioritize the health needs, then you concentrate on those that you think that can be handled. Then you work with them and start looking for solutions. What can be a local solution? Is it a question of money? Is it a question of infrastructure? Is it a question of what? All that work is done with them. And you are the facilitator, the health expert. Once you do all that with them, then you can then start budgeting and planning and budgeting and reach, then you can then approach a donor. Say, this is what we have, this community will have, and then the community may also have a commitment that based on what we have seen here, we can contribute this. Anybody seeing that start up will push it. Will push it. You will get a stereo financing. The problem is that the communities are not organized. They are not. So and the community is not. It's nobody until you go in there and find out what the community is all about and how it's kicking, what makes it live, who are the people who make it live, and all that. If you don't know that, it becomes a problem. But once you do this homework and do all this work, we've done what we've done with medical students, and it has worked. We have taken medical students out to do the community assessment for their field work. In one community in towards outskirts of Limbe, water was a problem, but there was a nice water catchment above the village, and the students saw it, and they said the kind of water that has come down from that catchment into a small area that they were drinking. The students, I told them, they did homework and said, Prof, we think that we can work with the community to build a good water system so that they can catch the water and then they can fetch it and it's clean and it's treated and all that. I say, bravo. Send them back. They made the community, made the chief. It was done. They themselves put their money, got the contractors, it was done. By the time those students were in their second year, those people were drinking water from that place. So diseases like diarrhea and all that could drastically reduce. So that is how you handle it. You can do the same thing with insurance. Again, through sensitization and promotion, let them understand the use of insurance. That since you can contribute 500, if all of us contribute 500, it can enable me to get care for 50,000 when I'm sick. And tomorrow when it's your turn, you also get that care. That's insurance.
Okay, thanks, Prof. So we see already that we have already opened some ideas where we can engage students, and by so doing, at the end of the day, they might also create jobs within the community health for the communities. Now, let me open the floor. I see we have new people coming. Let me open the floor for questions. And Mr. Glory, you have been in with us. Questions to Prof, and maybe your own input from universal health coverage in Nigeria.
Yeah, thank you so much, Dr. Benedict, and thank you so much, Prof. Good evening, everyone. I hope you can hear me from your end.
Yeah, we're hearing very well.
Okay, so I just want to share light on or possibly ask Prof on the aspect where you talked about modeling health insurance. You know, one of the key areas where you can actually get to at least a level of universal health coverage for all is modeling on the health insurance that you talked about. And I want to look at the low and medium income countries. It's been a challenge. I am with the WHO when it comes to health counter estimation. So I'm a consultant to the WHO. And over the past 6-7 years, I think have had to support the process of the health estimation across the country here in Nigeria. And one challenge we found out is in domesticating health insurance, particularly with the informal sector, because it's quite easy when you are talking about the formal sector, because the government has a way of deducting from their salaries. But when you want to now bring in the informal sector, it becomes challenging, because when you look at the core people who the UHC is actually referencing, you are talking about those at hard-to-reach areas, those that are within far reach to at least a level of health within the city areas and the metropolitan. So majorly, people who are of concern is how do we reach out to these hard-to-reach areas, and a large chunk of areas fall within these places. And then how do we get this the non-informal sectors to contribute their own premium to the health process? So it's a big challenge. So what do you think that government can actually do? Because I know very well for you to achieve UHC, every, like you talked about the human capacity development. So all aspects need to be working coherently, like they need to be a synergy between all the sectors and ministries. So you cannot talk about UHC without bringing in, UHC without bringing in infrastructure. I hope you can hear me, Prof.
Yes, I'm hearing you very well.
So what do you think? Do you think we can achieve universal health coverage, as in considering the target that we have, 2013, it's almost close by, so it's barely less than 9 years. Can we actually achieve that? And do you think we can actually model health insurance based on the advanced countries? Because I believe in replicability and applicability. Can we apply what is existing in other countries, in low, medium income countries? So what are your takes, Prof?
Thank you very much. Very good question. Very good question. You've introduced a good concept of a very big informal sector in Nigeria. And that informal sector, I also want to report that is also business, lots of business. Even sometimes in calculating GDP, the scholars have argued that people do the Nigerian system a disservice because that particular informal sector is not really taken into consideration, and that is very difficult to quantify. Well, basically, the truth is that all of us get sick, whether we're in the private, public sector, or informal sector. We all do get sick. And interestingly, that informal sector that you are talking about do have the money. They do have the money. Most of them are into businesses. If I'm not wrong, because in fact I know a lot about Nigeria. My wife is from there, so I know a lot of. So that informal sector, most of them are doing business. So the question is, can you also gather them? Can you bring them together for some common health action? The answer is yes. The approach remains the same. How is that informal sector organized? Who governs there? Who rules there? They have their leaders. They have their leaders. You say you take the same approach, come in with your team, work with them, identifying their needs, and you'll be surprised that, in fact, as far as I'm concerned, they are even much more likely to buy and develop some health insurance scheme than those who are even poorer than them. So they can be approached. It's community work. It's community participation, which nobody has addressed. Take, for example, you see all these guys, hawkers on the street, so many, thousands of them. You call a town meeting, you'll be surprised. They will attend. And even not all if all of them don't come, the message will go around that there is something that can help us. The idea here is that the treatment for your short episode of malaria, when you're lucky, is good when you can buy your artesunate and take. But artemisinin combination and take, and you get well. But supposing you don't get well and you need to get more advanced care and all that, and it becomes more expensive, somebody will buy the idea that, listen, yesterday I treated this disease for this and I spent this out of my pocket. There is a possibility that through some community contribution, that's how it is, through some collective contribution, we can even pay less for that service tomorrow. I think this is the whole idea. I think that they can be organized. I think, and I believe in really organizing, and I believe in implementing those primary healthcare concepts. Well, Nigeria, like many other developing countries, suffer the same fate. So it's not different because we have large populations that are poor, that don't have access to health services that we are talking about. So in answer to your question, whether will I attend this to 2030, my answer is no. My answer is no, because we have already spent almost from 2015 to now doing nothing. Doing nothing. We really have not done anything unless I beg to differ. All these countries that I've been mentioning, they have not started this health insurance schemes for their people. They are not organizing their people even to provide even alternatives. So what we need to do is also trying to begin to get away from the government. If the government doesn't do it, can the community do it? I think the answer is that yes, they can do it through this type of organization and participation that I'm talking about, and sensitization and education. So we might even get private insurance companies be interested in organizing these type of insurance schemes with these communities that I'm talking about. That's what I think can happen. Hello, Glory, you there?
No,
yeah, so
thank
you so much, Prof. So I think you strike a bit of a solution to that challenge. So now that's bringing the private sector into the system, that's the private health insurance into the system.
Yes.
But
yes.
now you know, when you talk about health insurance, one key thing is what's the quality of service provision because I am actually looking at the coverage. So now you look at the quality of services at some of these primary healthcare centers, which is while you were talking, you talked about the primary healthcare, which is one of the agenda that was talked about in 1978, and and the function is the major function of the primary healthcare is born at the primary healthcare centers.
Yes.
And also the chemists, the people who form probably some of these informal sectors, the traditional, that's the TCAMs, the traditional medicine vendors and all those stuff. So majority of their function is at the core of primary health care. Yeah. And now you look at the quality of services that is coming from there, you see that people who actually want to subscribe for health insurance may have some concern and wouldn't want to actually contribute such a premium for such a service that is coming from the primary healthcare centers and other health service delivering centers, organizations. So, and then when you look at because I have been able to look at the trends of the out-of-pocket in Nigeria and some of the West African countries and the Western countries, and you look at over a period of 11 years, 2000 down to 2018, you see there's a kind of a fall. There's an upward movement and a downward movement, sort of. We tend to achieve some success at a point, and then we fall back to a very high out of pocket, and then after a while, so there's this inflow that is not balanced, and it calls for concern because people subscribing for health insurance and then visiting an health facility and then receiving a poor service at the health facility may not want to subscribe for subsequent year.
Yeah.
So
the answer to that is that the good thing about putting together those schemes is that it's comprehensive. A lot of things are taken into consideration. You are looking at the capacity of the providers to provide, and you are looking at the quality of services that the providers will provide. And one of the key things is that you will not become a provider if you're not selected, if you don't meet the criteria. So that's a good thing. So that when that scheme is really fully operational, before it goes operational, all these things are taken into consideration, so that you don't just get any people coming into the scheme and all that type of stuff. Hospitals are selected, the services are selected, and everybody gets the care. But that is done, that homework is done in the whole planning process and in the whole contributing segment. And in fact, it is on that basis that the premium deductible is even determined. How much is it going to cost? Who is providing the services? Those people are also brought on board, and you have to be discriminatory, because sometimes when you are starting one where there is a diversity that you are talking about, you need to be discriminatory, so that at least you don't open up the system where those that are not qualified come in, or where you can have what we call moral hazards and adverse selection. You understand what I'm saying? So those things they have to be worked in whatever plan you are trying to put together. If we don't do that from the very, very beginning, we run into serious trouble. So I understand. So again, the traditional practitioners have their place. WHO has accepted them. They have accepted them. So it may be a novelty to say, okay, fine, we will bring you practitioner on board. Patients can come to you as long as you are doing what is acceptable. So, and you get paid for what you are doing, for the service that you are providing. So it may be a novelty. So because WHO has already accepted them. So the question is now to see whether you can now make sure that they are doing the right thing. Because one of the challenges in that traditional sector is that there are too many quacks in it. There are too many quacks, and you cannot be dealing with quacks.
Thank you so much. So you talked about selection, and
Yes.
in selection, and you know very well that there are chances that majority will not be covered. Recently, I just came down from a field assessment, and part of those I asked the question, are you covered under health insurance? A particular person told me yes, but the service center where I was actually given to go for my service is a bit far away. It's far away. I need to spend so much money, and there are no facilities within my region. So such a person still spends out of pocket even after having paid for an insurance service. So you now, do you think Africa and other low medium income countries can actually achieve universal health coverage by 2030?
A good question, but let me come back to, you know very well that the WHO plan, the primary health care scheme, was very specific as to how health centers are supposed to be centered, where they're supposed to be located, serving 5,000 population with a radius of not more than 5 to 10 kilometers walk and all that type of stuff. Now, the question is whether in practice this is done. But for universal health coverage, this has now to be reactivated so that it is done rightly. Because if it's not done rightly, you may have the services. What use is it having a service when people cannot reach there? Distance has always been a factor in health service utilization. We have known that for a very, very long time. Distance. So the whole scheme of WHO, primary health care, had been to bridge the gap between that distance and the population, the user population. So, and I think this has got to take priority. And if we are still talking about that nowadays, then it's really, really unfortunate. But whatever it is, but my basic answer to your question again is that based on what I'm seeing now, unless there is some dramatic action intensified, we know what to do. That is the thing. We know what to do. It's not that we don't know what to do. We know what to do, but we're not doing it. And if we're not doing it, we will not be able to go anywhere. As I said, 6, 7 years have passed already. And if we continue in this same light, we will not go. So I think what we should be recommending in this forum is that those things that we know that work to provide access, healthcare, access in all forms, medication, right, quality care, and all that, let's be doing them. We know that. And the question is this whole thing about government. And I think this is where I'm trying to run away from. If we keep insisting on government with poor governance, we will not have any healthcare. Communities, NGOs, civil society should begin to think seriously about organizing the healthcare of their communities. That's another thing I'm recommending in this forum today. For developing countries, Africa, Nigeria, Cameroon included. That's what I'm recommending. Otherwise, we'll not do that. And let's take it as a serious business. This serious business is about providing quality healthcare to our people. We only have 10 years or less to do that. We start today. It has not been done. We have the ingredients. They're all there. They're there. We have the human resources. We have the infrastructure. If it's not there, let's not start.
So thank you so much, sir.
Yes, let's not think about building more. Use what we can use what we have and make it functional.
Okay. Yeah, thank you very much.
I'm still with Prof. Sorry, I just had hello. Yeah, I just had a network issue now, so is Prof still on?
Yes, Prof is still on.
I'm on.
Okay, so thank you so much for that wonderful answer. So a giant stride in the health sector of Nigeria, that's the health system in Nigeria, which in 2014, the National Health Act was actually approved by the then Dr. Jonathan Goodluck in Nigeria. And one of the components of the National Health Act is to bring about the basic healthcare provision funding, which would actually channel some funds from the general budget, which is 1% of the budget, and other international support to help support the primary healthcare centers. So this is actually going directly to the National Primary Healthcare Development Agency. But my concern is it's been oblique, sort of. It's been marred with corruption. Yeah, so, and the entire system, corruption everywhere, and in achieving UHC, don't you think this is one key area which we must also channel some strength? Even in the pharmaceutical industry, we'll see the process of bidding. The bidding process has also been marred with corruption. So we cannot entirely cut off corruption from the process of achieving UHC. So what do you think? This still brings me back to the word synergy. One of the ways to combat corruption is to get the son and daughter of the soil to be responsible. I don't know if you get me. Do you get me? Yes, we did that here. Yes, in other words, when we were looking for people to run the pharmacy, where a lot of money comes in, we said you have to hire somebody, a son of your village, a daughter of your village, not from outside, so that they will have a conscience. If anything goes wrong, you know where they are, you can get them. You understand? Now, sometimes if you don't do that, I go and get people from outside, they have no vested interest in protecting that collective good, that public good for the rest of the people. They have no interest. They embezzle. So that is why this whole concept of community becomes very, very important. Are you a member of a community? What makes you a member of that community? We have to understand that. So if they give you a responsibility, are you going to fulfill it with honor, or are you going to disgrace the community? This is what I'm talking about. So what am I talking about? You get people that are known in the community that you can predict whether they'll be responsible or not. That's what I'm saying.
And so that if you can only get an expertise from outside to come and give the technical know-how and leave, but let the community person from that community be responsible, and then let's see how they will disgrace the community by not performing very, very well. That's how you solve some of those problems. That is what we've done in some cases here, and it worked very, very well. It did work very, very well.
Yeah, so thanks. So, sir, getting people from the community, over the time during the era of Dr. Ramson Kuti, who actually brought about the primary healthcare into Nigeria.
Yes.
So one of the key areas was human capacity development, whereby he allowed universities to start training people from the community, training people that are domiciled within the community to actually deliver the services, like sort of a community-directed distributors that are domiciled in the community. And you find out that after empowering these people, and then you ask them to go to the community, some of the infrastructures there are way as in limited. So they tend to like, okay, I don't think I can stay here. I have this capacity to as well deliver service in the town, in cities. So why should I be sent to my communities? So it's a big blow. It's a big challenge on the health system. Getting people out the community to give out the services.
So anyway, Glory, the thing is that, like I said before, we know the solution to all these problems. That's how I started. We know the solution. Now, you want to send somebody to go and work in a village where there are no lights, there's nothing. The house is not good. The house is not good. You can't do that. You have to take those things into consideration. Those specific situations have also got to be arranged to accommodate whoever you want to do the work. If that is not done, it will not be done. And I think this is where we have problems. In Cameroon, what you are mentioning is very, very correct. The government has trained people, hired them, but the preference for them is to work only in towns. So when the government sends them to the villages, they refuse. They're refusing for good reasons, because there is nothing in the village. In terms of
the same government actually spends money.
In terms of what makes your work environment conducive and comfortable for you to produce, there's nothing there. So you can't do that. But that you should be able to take care of that before you start thinking about sending people to take care of those problems. That's what I'm saying. Unless we think that our problems cannot be above us. It's all a political will. And I think my solution is that if there is no political will to organize and run a health system, forget it. It will not work. It has worked in other places. Why can't it work in your place? It can work. Why can't they work in Cameroon? Why can't they work in Nigeria? Why can't they work in other places? It is just the way the planning, implementation, evaluation, outputs, and all that is envisaged. If nobody is thinking about planning in those terms, it will not work. It will not work. We can talk and talk and talk. We know the answers. We know the answers. That's my basic position. We know the answers. All this is Ransom Kuti was a very good friend. I knew him very, very well when he was minister. May he rest in peace. May he rest in peace. We discuss most of these things, but in the long run, we allow sentiments and all that to overburden us. That nothing can be done, nothing can be done, nothing can be done. Of course, in the end, nothing is done. But I think that with the large sums of money that healthcare requires, and with even large sums of money that people give us from outside, we have not really used those funds wisely. We have not. And that's where the problem lies. And I always say to myself, if a donor sees what you are doing locally, they will support. Don't go to a donor where you don't have nothing to show locally. You want primary healthcare to work in this area. What have you done before looking for outside help? The help can come right within your own community. From your parliamentarian, from your teacher, your dad, whatever it is, who can contribute, it can be done right there. Organize that community first, sensitize them for their need to participate in their health development. That's what I think can be done.
Thank you, Prof. Thank you, Glory, for giving us a little bit of insight into the situation of the universal health coverage in Nigeria.
Yeah.
Are there other questions for Prof? Mr. Ayin, I saw you on mute.
Yes, Doctor. I'm really grateful for the interactions, Glory and Prof. As I noted some key facts.
Okay, we're already 1.5 hours. I think we should be thinking
Yes, we are rounding up now, Prof.
Yes.
My own observation. Now, what Prof said was
So it was good to have Glory. It was very good to have her. I think that's exciting.
I mean, the interaction was so good, and what I learned was
to see another perspective.
Is not financing. The problem
okay, Ayin is not talking.
The problem is really the problem of accountability.
Is he talking?
Yes, Mr. Ayin, please, can you increase your volume?
Okay.
Can hear him at all.
Hello.
Yes, please.
Yeah. What I'm saying is that the problem, as I gathered, is not actually the problem of lack of money per se, but it is a problem of lack of trust, lack of accountability, because the governments have received huge sums of money. They receive money for taxation, but this money is not put into use. And as I gathered from what Prof is saying, we cannot go in now to start taxing the government, or it will go political. What we have to do is that at the level of organization as we are, what can we do to do what the government is not able to do?
Right.
And as I noticed, he was talking about this problem of involving local organizations in providing health insurance. I was so happy about that one, because it is really being tested, because we know that in this village organization, we have what they used to call impeding trouble fund.
Yes.
They are already practicing it. It means that if we are able to organize them in a more professional way, and maybe trade organization like in Jangi meeting, they have those funds inside, and people are contributing. So the problem is that why is it not going global? Why is it not going? Because the lack of trust. If the government organizes a health insurance, people will give. But the problem that people will not give, because they are not trusting that this money will eventually go to serve their purpose. But now we cannot go in, as I'm saying, to start examining government now, because it will turn political. What we have to do is that, as I say, Prof is saying, and Mr. Anwaka, we should look at ways as which we can involve ourselves locally, going to those communities and helping those communities to organize themselves and make this kind of what they're already doing, like in the Njangi, they're doing the health, trouble fund, that somebody can be sick, they help. I know that happens. Even when people die, they help. Can they help them to do it more professionally and involve those communities? And eventually we can come with an umbrella organization, as I'm proposing, to help organize, maybe in local communities, form an umbrella organization that these other village communities, local development meetings will be able to be like, what can I say, will be an umbrella organization helping them to keep those funds. And then I think the health insurance can work in that way without actually, keeping aside what government can do, because government can do what they can do if they're willing to do. Because what I heard Prof saying is right. It's not that we don't know what to do. They know what to do, but at times governments can have their own priorities. We are not basing on health. So
let me just give you a good example. I don't want to interrupt you, but just hold on your idea. Don't go. Let me give you a very wonderful example that I just lives here. We have a group, a Mancon group. We call it Aquate, which means helping each other. Now, somebody had a stroke. They were in a meeting, and that person had that stroke right in front of us. And then he was taken to the hospital. So the hospital bill was very, very large. The man didn't have any money. And now, and turned to us. And our bylaw says that when somebody is sick, you give them 10,000 francs. 10,000 francs. Imagine that, isn't it? Okay. But this group has about 20 million francs in the bank. Are you seeing that? And they are concerned about investing that for themselves. So I put up some communique in the group. I said, this nonsense must stop. I am going to start a contribution of 10,000 francs myself. And I want everybody to contribute something and give to that man before he dies in that hospital. Aha! The response was unbelievable. So in less than 24 hours, we raised 250,000 francs and we sent to that man. And he was able to pay his bills and come out of the hospital. And then it's even undergoing rehabilitation. So you see, this is typical African. This is typical us. We don't give priority to where it belongs. We are much concerned about ourselves, and even among ourselves, we think that we are protective. We are not protecting ourselves because it could have been another person and they will die in that hospital because the bylaw says they give them 10,000. Why can't they organize that through a company that is an insurance company and everybody is covered very well? That's what I'm talking about. Private insurance.
Oh, it seems as if my battery of my computer will be running down. So if it runs down, then Mr. Ayin will take care and Curtis. But since we are rounding up, what I wanted us to remember is Prof talked about us not relying on the government. And now with the digitalization in both the financial sector and the health sector, it means that with the fintech, even Prof Akwate can come up with a modality whereby people are not just building reserves for economic growth, they are also building reserve as an health insurance concept within the fintech communities. So that is what so Mr. I, you still had some points to talk to. You can be talking to while I find out how I can get my system on charge. Yeah.
No problem.
Thank you, Doctor. As I was saying, there was a great idea that Prof also talked about.
Speak loud, speak loud, speak loud.
Also talked about concerning
Yes.
government spending a lot of money in centralized big institutions which are not accessible to local people. That governments can be encouraged to instead build up or improve the capacities of the district hospitals, primary health care, and so on. That was great too. And I think that if there's a good partnership between the primary health care institutions, which are maybe more accessible to the local communities, and with this development of health insurance involving local communities for the moment, village organizations, so on, with an umbrella organization which we can form to help them professionalize them, I think that's the way that we can take maybe a model from how cooperative societies began. Because I can remember banks were, I'm taking example from the financial industry, banks were first of all at the forefront. But when banks started not delivering the goods, banks started locking up and going with people's money. That's when local cooperative societies started having a lot of strength. And then they've grown up now and they are even more vibrant than the banks.
Yes.
What I want to say is that if the government is not able to deliver this, this important, goods of insurance, we can go back and copy the same scheme.
Exactly.
By making local communities to start their health insurance scheme as a cooperative.
Yes.
And we can form an umbrella organization, just like the local communities, cooperatives have umbrella organizations to help them organize, train their personnel, give them the know-how, and they manage these resources themselves. Exactly. We are now being a supervisor that will have Kamku supervising the cooperative societies that are actually flourishing. The health insurance can start flourishing from local communities themselves, they be it themselves, do it themselves, and will give them the know-how and then supervise. It can work so well within the government aside. That is, I was just taking in to support what Prof and Mr. Walker talking about. We can do it because the will is there, but we don't have to. And with that, they can manage you well because, as Prof was saying, the person who is at the head is from that community. People know him so well, he cannot escape. And the people are looking, they know him, they know the kind of people that they can get. And they know that it is their interest, they are looking at their own brothers and sisters. I think we can go a long way to achieve it that way. Thank you, Prof.
Thank you. I think that's a very good thing you are bringing there. And eventually to solve a glorious problem, when you have an organized payment system for healthcare like that, then you can have a specialist hospital right there in that village. Yes.
Yes.
Yes. What stops it? Because after all, You can build it and people will be working there, they live well, and they take care of the community.
Yes, we just supervise. It is great.
Yes, yes. So I think it's absolutely right. Because this thing about government, it will get us nowhere. They cannot.
Yeah,
let's
no way.
organize,
Yeah.
let's organize health coverage around the community. Yes.
Yes.
And we'll get everything that we need there.
Yeah, thanks, Prof. We are rounding up. We are almost 10 minutes behind the scheduled time. But it was a very important discussion, and it is a discussion that we have to continue. I hope we are going to use the hub, the Community Digital Health Hub, to talk to all these key issues on how do we use the current technology in the financial sector, in the healthcare sector, in the education sector, to bring healthcare closer to the communities, and also transfer the governance of healthcare from the state, or at least activate people to transfer the governance of their own community health to their respective communities, while the state takes care of what the state can do or what they don't want to do. Yeah, so
great.
That I would like allow Prof to give us the closing remark, and we round up while we round up.
Thank you very much. It's been a pleasure to again meet with you, exchange key things as we look at Africa's health situation today and tomorrow, and how we are going to improve it. And I think that I'm glad to report that I think we have a dynamic group here, from Dr. Tenga to Goodman to Keltis, Glory that has come in, and many others in Cameroon that we are going to be working with. We have the capacity. I see in Quinty Felicia, I didn't hear, maybe we'll talk next time. But we have a good group. And this particular topic. Yes. Thank you.
It was very interesting. Part of you.
Thank you.
But when we are talking, we should know that government with a taxing system in Cameroon, it will be a little bit difficult. I don't know. Opening all those things, the taxing system in Cameroon is too heavy for some of these villagers or some of us.
Yes. Well, you know, like any money matters, we can still overcome it. Like the example that Goodman gave about the credit unions now, and the wahala with the banks and all that. When they were starting, nobody gave them any credit. They didn't think it would work. The same thing with health. Health is money. Health is money. If you are healthy, you make that money. Without health, you will not make it. I think that there is room for us to overcome all these difficulties. Once we have it going, and remember that we're talking about collective efforts. If it was one person's show, it would be very, very difficult. When many people put their heads together and are working on something, I can guarantee you that it will work, and it will work very, very well. That is what I've seen. That's what we have seen, and that's what we should be pushing for. So I think, like Dr. Bernadette said, we have more opportunities to talk. It's been a pleasure exchanging on the universal health coverage, a very, very important subject in public health, which I think all of us, when we put our hands on deck, we can transform our communities, because people don't need to suffer to get basic healthcare or to get quality healthcare. Money is not the issue. It's just how we organize ourselves, and it will be paid for. And community health insurance is a good way. Thank you very much.
Thanks very much, Prof. Thanks. I just saw that one person has been struggling to come in and out with this Intel A16. I really appreciate the fact that he or she has really tried, and I discovered that they have poor network system. I hope that next time, if possible, please always put in your questions within the chat. Yeah. And what Madame Quinty brought about regarding taxation, that is a topic that we are going to, within the next year, talk about startups within the health sector, about the fintech, and I hope Mr. Glory is going to bring us experts from Nigeria, because the technology in the finance sector is very strong in Nigeria. And we should always remember as a take home, no government works without taxes. So, but how do we make our business to also have return for us and for our communities, even within the framework of taxes? So taxation should not stop us from being innovative, and also taxation should not stop us from mobilizing towards improving on our health through generating wealth for our communities. Right. With that, I will say, thanks everyone. Let us continue with this discussion within our forum. And over the next weeks, Prof and myself, we are going to come up with the plan for 2022, and then we share within the broader forum. Thanks everyone.
Thank you. Thank you.
So bye.
Bye. Bye. Bye. Bye. Thank you.
Bye.